So for this module, we're going to talk about psych medications. We're going to go through antidepressants, anxiety medications, antipsychotics, and a little bit on mood stabilizers, and then have some slides on when to use which medications in those classes. So an overview of depression and anxiety. Major depressive disorder is one of the top reasons for disability in the United States. It affects a large number of people in their lifespan. Obviously not all at once, but a large percentage of patients will experience some kind of depressive episode, especially your patients with a lot of comorbidities. Anxiety, annually 18% of the United States adults have an anxiety disorder. That includes generalized anxiety, social anxiety, other panic disorder, panic disorders, other anxiety disorders, but totaling 18% of U.S. adults. And partial response to medication is not acceptable, so patients don't like when they just have partial response. They want total remission. As a primary care provider, it's often their role to first identify depression and anxiety through screening, early identification, assessment, primary treatment, and then referral when necessary. And you always want to check for hypothyroidism prior to treating depression, because hypothyroidism displays as that. So you can actually just give thyroid hormone to supplement treatment. So in anxiety and depression, this can result from the interaction of the central nervous system. There are many structures involved within the brain, usually thought to be a byproduct of neurotransmitter dysregulation. So most of our medications throughout treatment of mental illness have focused on serotonin, norepinephrine, and dopamine, either a lack of or excessive neurotransmitter of one to all three of those. We're now looking at GABA, which is an inhibitory neurotransmitter, and glutamate, which is the excitatory inverse, I guess, of GABA. One's excitatory, one is inhibitory, and then acetylcholine. We're now looking at those as better options or additional options for treating mental illness. So the classic theory of depression is that it's the monoamine theory, which is a deficiency of norepinephrine, serotonin, and or dopamine. And so dysregulation of the brain results in lower norepinephrine, serotonin, or dopamine, which leads to depression. So our antidepressants come as various different classes, which have different effects on norepinephrine, serotonin, and dopamine. Here's where they're broken down into different classes, and in a few slides we'll talk about each individual drug in those classes. Anxiety is thought to be a product of GABA, glutamate, norepinephrine, and serotonin, which is very similar to depression but different neurotransmitters. So how long you treat anxiety and depression depends on the risk of occurrence. It's not necessarily a lifelong treatment, but it can be, and it's recommended lifelong treatment if you have a patient under 40 years old with 2 or more prior episodes, or a person of any age with 3 or more prior episodes. And with each subsequent episode, the risk of recurrence becomes greater and greater, so you're going to want to continue lifelong treatment. Medication options are medication, psychotherapy, or combination therapy. For almost any mental illness, psychotherapy is more effective than medication, the exception being schizophrenia. So psychotherapy should be recommended for all patients, and combination is the most effective, combination psychotherapy and medication. But most patients want to go the medication route because it's less expensive and it's quicker. It's quicker to take a pill than to go to therapy sessions once a week or once a month and have to continually work on those aspects. Initial medication choice is based on things outside of how effective is this medication. So antidepressants, each class of antidepressants are equally effective at comparable doses. So the differences you see are in adverse events, you know, overdose potential, or drug interactions. So you're going to look at things like familial response or a history of response. So if a patient knows that their mom was on an antidepressant and they responded well to Wellbutrin, it's likely that that patient will respond to Wellbutrin also. So that may be one to go forward with. Concurrent medical history. If you have a patient who has fibromyalgia, then you may want to start them on Cymbalta, because Cymbalta is used for fibromyalgia also. So kill two birds with one stone. You may want to look at presenting symptoms. So if they have fatigue or agitation, it'll steer you towards one antidepressant. Drug interactions, adverse events, patient preference, and possibly most importantly, cost, because if they can't afford the medication, they can't take it. And failure to respond to one medication in the class does not predict a failed response to another in that class. That's really important with things like SSRIs, because usually when you try one SSRI, if they fail, the guidelines say to try another, and then possibly even try a third. So let's talk about selective serotonin uptake inhibitors. So these are your SSRIs. They block the reuptake of serotonin and increase the serotonin level in the brain. So it prevents the nerves from reuptaking serotonin, because they want to reuptake it to use it again later when the next stimulus comes down. So the good thing about it is they're safe in overdose and tolerability, so they're first-line treatments, and they're inexpensive. They're all available in generic forms. Class-wide side effects, the highest rating is drowsiness and sexual dysfunction. Next is weight gain, and then there's insomnia. So you'll see it's interesting that 11% of patients have insomnia and 17% have drowsiness. So it depends on how it affects your patient. If they get drowsy with it, have them take it at bedtime. If it causes insomnia, have them take it in the morning. If it's unbearable, then switch to another medication, because they may not have that same side effect. At the bottom it says that the patient may experience an increase in agitation or anxiety in the first 2 weeks. That's not uncommon. So if you're using these for anxiety, you may have to give a benzo to cover those first 2 weeks. A patient can take as needed. These side effects subside after 2 weeks, along with the drowsiness, any type of upset stomach, or headaches that can happen. Those subside after the first 2 weeks. For most patients, they don't know that they really don't know they're taking it after 2 weeks, because it's so well tolerated. The one medication, the one side effect they will complain about is the sexual dysfunction after that 2 weeks, and we have medications we can switch to if that's the case. So quickly, a little bit about each SSRI. Fluoxetine has a really long half-life, so it has a long duration in the body. It's great for patients who are non-compliant, and it doesn't have the need to be discontinued slowly like other SSRIs, so you don't have to worry about those withdrawal symptoms of SSRIs. You want to check for drug interactions, because it's a potent 2D6 inhibitor. It can be activating in some patients, so watch for it in patients who are agitated or anxious, and it's a pregnancy category C. Paxil is the only pregnancy category D SSRI. It's a potent 2D6 inhibitor, and it's more likely to cause sedation and nausea and sexual dysfunction. It has a very short half-life, so it's not good for patients who have compliance issues. Even missing 2 doses can cause some kind of withdrawal symptoms, some flu-like symptoms. Zoloft is a good SSRI, better absorption when taken with food, more likely to cause diarrhea than other SSRIs, but really the difference is negligible. It's very well tolerated. Celexa, again, very well tolerated. The only difference with it is that it may cause arrhythmias at higher doses, which is why the FDA has limited its maximum dose to 40 milligrams a day. And escitalopram or Lexapro has no drug interactions and may also cause arrhythmias at higher doses. Luvox is the last SSRI that is not approved for depression. It's actually approved for obsessive compulsive disorder, but it works the same and has very similar side effects. The one thing you want to watch for this one is drug interactions, because it is a substrate of 3A4 and 1A2, so it does have quite a few drug interactions. SNRIs, or serotonin norepinephrine reuptake inhibitors are basically SSRIs that also block the reuptake of norepinephrine. So they're going to have all the same side effects with a few extra ones because of the norepinephrine reuptake blockade. Examples are duloxetine, venlafaxine, and desvenlafaxine. They don't show a better response than SSRIs, so they're not preferred over SSRIs. They're just another option you can choose from. And the adverse effects can be a dose-related blood pressure increase, so you don't want to use these in people who have uncontrolled hypertension. Some patients may have a decreased appetite because of that norepinephrine increase, and they can have insomnia or sweating because of the norepinephrine. If that happens, again, just have the patient take it in the morning. Duloxetine is contraindicated for patients in uncontrolled narrow-angle glaucoma. You want to use it in caution and liver disease. The blood pressure increase is negligible, so it'd be a good option for those patients, and can also be used for fibromyalgia, chronic pain, and neuropathy. Venlafaxine doesn't have any drug interactions to note. You can titrate it up quickly, but you must have a good liver to convert it to its active metabolite. Desvenlafaxine is the active metabolite of venlafaxine. It should be increased slowly, and it's expensive. It's name brand only, so unless your patient has just really bad liver function, there's no benefit for this drug over Effexor. It's just an increase in cost. Wellbutrin has its own mechanism of action. It blocks the reuptake of norepinephrine and dopamine, which is unique, so it can increase a patient's energy level. It has the lowest incidence of sexual dysfunction because it lacks serotonin blockade. So, which that's the reason for the sexual dysfunction is serotonin blockade. So if you have a patient who complains of it, you can switch them to Wellbutrin, and most patients are have good results from that switch. You can also use it for tobacco dependence, which may help a patient who wants to quit smoking also, and it can lead to weight loss. But there are some downsides. It decreases your seizure threshold, so you can't use it in patients who, or it's a very big risk to use it in patients who have a seizure disorder. Here we go. Adverse effects, nausea and vomiting, just like all antidepressants, that first 2 weeks. Insomnia, because it can be activating, and it's very low risk of serious skin reactions. There's a dose-related decrease in seizure threshold. It is contraindicated in eating disorders like bulimia and anorexia because it leads to electrolyte abnormalities, which can lead to seizures. Mirtazapine enhances serotonin and norepinephrine, so it has an atypical mechanism of action also. It has lower anxiety and GI side effects and a low incidence of sexual dysfunction. Side effects are sedation, it's a big one, and weight gain. But weirdly, weight gain does not increase as you increase the dose, so we don't have to worry about that in patients if they're worried about going to the highest dose of mirtazapine. So trazodone and nifazodone are serotonin reuptake inhibitors, but they have worse side effects. So they have orthostatic hypotension, sedation, cognitive slowing, and dizziness. And trazodone can lead to priapism, and nifazodone can cause liver toxicity. So these aren't used very often anymore, except for at low doses to help with sleep. Tricyclics. Some examples are amitriptyline and nortriptyline. Their adverse effects, you can see there's a lot more here than our other antidepressants. Plus you can have orthostatic hypotension and heart blocks and arrhythmias. So you have to taper them over several days. There's a lot more side effects, and there's a bigger risk for overdose or death due to overdose with these medications. The tricyclics, and now we're on to MAOIs, both of those are really not used very often for antidepressant effects anymore. Your MAOIs increase norepinephrine, serotonin, and dopamine by blocking the degradation, but there are dietary restrictions. Because of that, you have to have a diet low in tyramine-containing foods. It's not worth mentioning all of them. It's better just to Google that, because it's basically aged cheese, aged meats, processed stuff, caffeine, chocolate, beer, or any alcoholic drinks. It's very limiting. Causes a lot of adverse effects. and there's a lot of medication restrictions with it also. So because we have other more tolerable options, MAOIs aren't really used anymore for depression. They're really mostly looking at like Parkinson's. St. John's wort is an over-the-counter or herbal medication that sometimes is used for depression. It's not regulated. The efficacy has mixed results, and there's a lot of drug interactions. That's the one thing we worry about with St. John's wort is those massive number of drug interactions. So you want to ask your patients who have depression if they're taking it, and if they are with other medications, we want to ask that they maybe switch to something else. So choosing the right medication. This is any of the reasons you may choose a different medication for a patient. So looking at that, when would you maybe choose one or the other? So Lexapro or citalopram and escitalopram, great for low risk of drug interactions. Fluoxetine, which has a long half-life, is good for patients with compliance issues, or it can be activating. So if your patient, kind of is sleepy all day, it's a good option. Mirtazapine is great for patients who present with insomnia. So like if they're up all night worrying, or they don't eat, because they're worried all the time as a part of their depression. Mirtazapine is great for patients who need sleep or need to eat and gain some weight back. Bupropion is great for patients who lack energy or have sexual dysfunction or who have tobacco dependence. So think of mirtazapine and bupropion and their what symptoms they really help treat as opposites. One is sedation and causes weight gain. The other one causes weight loss, more energy, and can cause insomnia or give someone more energy. Duloxetine or Cymbalta you can give to a patient if they have pain or fibromyalgia, and SSRIs are best for patients who you're worried about. You may worry about overdosing. It's very hard to overdose on SSRIs, which it takes more than more than a month of prescription, 30 tablets, well over that, to overdose on an SSRI. Here's a list of combinations to avoid. You can see some of these: paroxetine, pregnancy, sexual dysfunction. Going down the list, you can see all there, and you can see at the bottom St. John's wort. I put all patients just because we have better options that are more effective and have less drug interactions. It's just really not worth the risk. Serotonin syndrome is a potentially life-threatening condition associated with increased serotonergic activity. You can see there the effects of it. I actually know somebody who was diagnosed with this. It wasn't that they were on one SSRI at a really high dose. She was actually taking several serotonergic medications, and it's not just our psych meds that have serotonergic effects. Tramadol, an opioid, has serotonergic effects. So does linezolid, an antibiotic. So the person I know who was taking it was taking 2 antidepressants, tramadol, a triptan for migraines, which has serotonergic effect, and one other medication I can't remember. And when she had that final one added, that was what caused her serotonin syndrome. So she basically presented to the hospital with what they thought was a heart attack, but the symptoms never subsided, and her labs didn't indicate any type of tissue damage. So finally, when they did her medication reconciliation, that's when they realized they thought she was having serotonin syndrome. So the way you treat it is you discontinue serotonergic medication, you give supportive care. If support fails, you can give cyproheptadine, which is a serotonin antagonist, and they usually resolve within 24 hours of treatment initiation. But it can be really severe, so you want to look at all the medications a patient's on. It's usually that patient has 4 or 5 serotonergic meds, not someone who, possibly takes more, higher than the recommended dose of one medication. Response to medication. So some symptom improvement is seen within 1 to 2 weeks of initiating treatment. Full remission may not be seen between 8 to 12 weeks after initiation. You want your patients to know that they're not going to see a full effect for 2 to 3 months. Anxiety and agitation are usually first to resolve, but they may not see a return to normal appetite and sleep pattern until after that, and then the resolution of their actual depressive symptoms. And patients who have no response within 4 to 6 weeks need to be switched to the next step in therapy. There's just more information about those classes of medication. A lot of this is a repeat from earlier. So benzos, or GABAergic medications. So they enhance GABA, which is an inhibitory neurotransmitter. These are often used for anxiety, as anticonvulsants, muscle relaxers, sedation, or for anterograde amnesia. They do have abuse potential. You have short, intermediate, and long-acting agents, and they're great for anxiety disorders, especially when you're putting someone on an SSRI and you need something to bridge the gap or something PRN. So here's a list of your benzos, where they fall in how quickly they act. Abrupt discontinuation of any long-term benzo can lead to seizures and hospitalization, so you want to taper it. If a patient has been on a benzo longer than a year, you're looking at months of a taper, and there are recommended ones out there to cut it. Usually, cut it by 25% of the total dose every so many weeks, and then until you get to half the dose, and then drop it by an eighth of the total dose thereafter. Antipsychotics, we use these to treat the symptoms of schizophrenia. So your positive, negative, and cognitive symptoms. We have different areas or different classes of antipsychotics, typicals and atypicals, which we'll discuss in just a minute. All antipsychotics have a black box warning for patients with dementia. It increases the risk of death compared to placebo, and they're due to cardiovascular or infectious events, usually pneumonia. So they're not recommended for patients in dementia, but at some point you may have to use it. It's a risk versus benefit, and then when you have someone on it, there are regulations on how often you have to try to decrease those doses. So in clinical practice, all antipsychotics are effective for positive symptoms. For negative symptoms, you want to avoid typical antipsychotics or the older antipsychotics and higher dose atypicals. Cognitive symptoms, you want to try reducing their anticholinergic or benzodiazepine doses. And cognitive symptoms are, memory impairment and a working memory loss, so being able to take what they learn and applying it to a new situation. Affective symptoms, so their mood, you may need to augment with a mood stabilizer. And suicidal symptoms, you may be looking at clozaril, which is an atypical antipsychotic, or lithium, a mood stabilizer, which are both approved to reduce suicidal ideation. While we mentioned suicide right there, I know that I left off a brand new drug that just hit the market for depression, esketamine. It's just been approved, I think, about a week ago for treatment-resistant depression. It's hitting the market now. It's an intranasal spray. Seems to be fairly tolerated. It has a REMS program that the prescriber and the facility have to sign up for. It's not something that will be available outpatient, or you'll have to go to the emergency room, a hospital, a doctor's office, or somewhere like an infusion center to get it, because it requires monitoring afterwards. So there's a lot of information out about it now. I won't dive into it too much, but it's very interesting. It's working under the glutamate neurotransmitter, so it's brand new. It starts working within a few hours of treatment, and they're actually looking at it for suicidal ideation. So patients who are acutely suicidal getting symptom relief within a few hours. So move on to antipsychotics. Antipsychotics have two classes. Typical antipsychotics block dopamine, and then to a lesser extent those other receptors. So dopamine blockade is what gives you relief of positive symptoms. Atypical antipsychotics have a greater effect on serotonin receptors, along with dopamine and those other receptors mentioned for typicals. So that's the difference. Typical antipsychotics don't work on serotonin receptors. So you can see here's a list of medication with their D2 blockade potency. So Haldol, these are all atypicals. So Haldol and Prolixin are your highest D2 blockade, which have less sedation but a higher risk of movement disorders or extrapyramidal side effects. Here's a dose equivalency chart for if you ever wanted to change a patient to another medication. More talk about high potency versus low potency. Almost all of them are metabolized through cytochrome P450-2D6. They have half-lives around 20 to 24 hours, and there's no well-established therapeutic level or serum level to draw for a patient. It's usually based on symptom control versus side effects. Atypical antipsychotics, you can see at the bottom of the list, are the newer medications, so Abilify, Zyprexa, Invega, Seroquel, usually Clozaril, which is technically our most effective atypical antipsychotic, but it requires blood monitoring for agranulocytosis and has side effects, so it's not used as often. But it is approved for treatment of refractory schizophrenia. So second-generation antipsychotics are used in a lot of psychiatric disorders: schizophrenia, treatment-resistant depression, bipolar disorder. They differ from first generations through varying degrees of serotonergic and dopaminergic activity. So even atypicals, they don't compare to each other very well because some bind to dopamine better, some bind to serotonin, some don't bind to dopamine at all. So they all have varying degrees of side effects. So you can see here suggested monitoring for second-generation antipsychotics. You can see weight and BMI circled there because these do require metabolic monitoring for their because a lot of these cause weight gain, diabetes, hypertension, and hypercholesterolemia or metabolic syndrome. Here's a good chart comparing atypical antipsychotics. I believe these are all that are on the market right now, except for pimavanserin, which is fairly new. That actually has no D2 activity, no dopaminergic activity. We haven't used it yet. It's used for patients who have Parkinson's. That's its only indication at this point. I haven't seen it used, but that's the only one that's not on this chart for comparison. So last section, I believe, are hypnotics or sleep aids. So we have Zolpidem, Zaleplon, and S-Zopiclone. So you'll see them a lot of times called the Zs. They're fairly well tolerated. You have withdrawal symptoms or insomnia when they're used chronically and abruptly discontinued. And you want to make sure the patient takes immediately before bedtime and is able to get 6 hours of sleep with these. So here's a comparison of all your hypnotics, so some benzos that are used for sleep and your Zs. You can see that on the bottom, Zolpidem, Zaleplon, and S-Zopiclone. The real important part of this, to me, is looking at that duration. So the bottom line, Zaleplon, great for patients who have trouble falling asleep, but its duration is only 2 hours. You need, for patients who can go to sleep but need help staying asleep, you need to really look at Ambien CR or Lunesta with that longer duration. That might help those patients out a little bit better. Melatonin is an over-the-counter medication that can be effective for patients with interrupted circadian rhythm that you can see listed there. Common range is up to 10 milligrams. And just remember, OTC products are not standardized, so and most provide higher than necessary doses. Ramelteon is a prescription melatonin agonist, very similar to melatonin. I've personally never seen it really used and be more effective than melatonin. And it just doesn't seem. It seems to be way more expensive than it needs to be. The only consistent effect is it's been shown to reduce sleep latency by 8 to 15 minutes. So they get to sleep 15 minutes sooner than they would have, and total sleep time is increased by a whopping 20 minutes. And there's no improvement on awakenings after sleep onset. So if you have trouble staying asleep, you still have trouble staying asleep on this medication. Tasimelteon is a very similar medication to Ramelteon. It's only indicated for non-24-hour disorder. So this is for patients who may be blind and have a hard time regulating their circadian rhythm. Is there any benefit over the other medications? Probably not, but it's the only medication with that indication because they're the only medication who asked the FDA for it into the studies, not because it's the only one that works. So this would probably be, to me, you would try, for both of these, you try melatonin, then you would try Ramelteon, then you would try Tasimelteon if nothing was effective. So mood stabilizers, used for patients with bipolar disorder. One of the most commonly used ones is lithium. It's excreted through the renal system. It's contraindicated in patients 12 and under in the pregnancy category C. You do have to have serum levels drawn, so your therapeutic goal is between 0.6 and 1.5. Where you want labs drawn at least 5 days after every dose change, and then you can get up to every 3 to 6 months. You can see with the symptoms of toxicity, you want your patient to be aware of that. Because lithium, while it doesn't go through cytochrome P450, it does go through the kidney. So anything that affects kidney function, any drugs, diuretics, things like that, will affect lithium levels. Plus, the body thinks that lithium is sodium. So anything that affects sodium, like NSAIDs or dehydration, which causes sodium retention, will cause lithium retention also. So it doesn't have any cytochrome P450 interactions, but it does have other drug interactions where sodium and where kidney function is concerned. Other mood stabilizers are you see here, we've talked about in previous categories, so I'm not going to go over them again. But you really want, in primary care, you're really not going to be managing the doses of these. You just want to watch for if there's any drug interactions with another medication you're starting, or possibly continuing what the patient was already on, or if they come in complaining about symptoms of toxicity or side effects. Here are your goals of treatment. Fairly straightforward. Some non-drug approaches. One additional side effect is that antidepressants do have an increased risk of suicidal thinking in adolescents and young adults. It does not correlate to an increased risk of successful suicide attempts, but it is a black box warning for patients. So you let them know if they start on something, if they have those thoughts, it's the medication to let you know, let their pharmacist know or somebody, that way the medication can be changed. And here's a slide on when to refer patients for treatment beyond primary care. And really it's anxiety and depression. First line choice can be treated out in primary care. Other than that, if you suspect bipolar disorder, schizophrenia, suicidal ideation, drug abuse, they really need to be referred to a different practice. If you have any other questions, let me know. I have numerous references on this. So you can take our psych class this summer. If you're really interested in this class of medications, we'll go in much more in depth. Where this is 1 week, here it'll be 1 to 2 weeks for every class of medications this summer.